All right, welcome to Evan the Counselor Live. I'm Evan the Counselor. We have a great show for you today, as always. So, for this one, I don't think I've ever laughed so hard making a podcast. Today we have Haley. Haley is your psych pharmacist on TikTok and on Instagram as well. Actually, I think she has something keto related, but we'll talk about that later. Her Instagram was initially keto related, but then she realized people were very interested in the work she does, which is a pharmacist, but she works in mental health on a mental health unit and specializes in mental health medication. So when I came across her profile, I was pretty blown away because she goes really in depth into all the psych meds, and I really have learned a ton from her. So I'm a fan, and I came across her, and I thought you all would be as interested as I was. So that's kind of how I pick my guests. I find them, and I'm like, damn, that's interesting. I think you all will find her interesting, and also hilarious. She is quirky as hell. We had about like an hour of technical difficulties before this, almost to the point where it was like cosmically wrong. Like every possible thing went wrong, and we were just cracking up, and it continued into the actual recording. So I was pretty much fighting back laughter the whole time, and just because she is so damn funny. So I think you'll really enjoy this conversation. So without further ado, here's Haley, your psych pharmacist. All right, welcome to Evan the Counselor Live. I'm Evan the Counselor. I am super excited about our guest today. Her name is Haley. She is your psych pharmacist. That's right, your psych pharmacist. Haley, what's going
Yeah.
on? How are you?
Hey, Evan. I'm really good. How are you?
I'm good. We've been, for those of you just joining, we have been having like technical issues for an hour, and hilarity has ensued. So this has been her webcam is just going in and out. It's absolutely hilarious. So we'll see how this looks on YouTube. So anyway, I came across Haley on TikTok one day. I was sitting there minding my own business, and I see this person come on, and it's your psych pharmacist. I'm like, what is a psych pharmacist? I'm like, well, I know what a pharmacist is. And Haley, we're gonna have to accept it, the in and out.
Yeah.
Literally, for those of you who are just listening on podcasts, her webcam is like zooming far out and then in, and it's pretty damn funny. So we're gonna try to ignore it and not laugh as much as we can.
It's like tracking me or something.
It is tracking you. It's like it's really
But I'm but
you're
I'm
really
not even
sus.
moving. I'm
You're
not even moving.
Yeah, it's like Alien versus Predator or something. It's like honing in on you.
Yeah.
All right.
Okay, so anyways, you found me on
Anyways,
TikTok.
anyways,
I showed up on your FYP.
I'm sitting there, right, minding my own business. Here comes Haley on the FYP. And I'm like, you're psych pharmacist. I'm like, that is so cool. And I started watching your videos. I'm like, this is like the 500 level class of medication. I'm like, oh my God, I have to like pay attention here. This is like some deep bio stuff. But I was absolutely like blown away. I thought it was so cool what you were doing. And clearly, you're starting to build up a following, and your videos are doing awesome, and people are really engaging with them. So yeah, I'm super excited to have you on and hear more about you, and be able to pick your brain a little bit.
Thanks, Evan. That's really cool. That's kind of how I kind of just showed up out of nowhere. I made a video about bupropion, and like people really liked it.
The Wellbutrin, huh? People,
Yeah.
Wellbutrin fans out there. We'll do that. So we're live on TikTok as per usual. And so people are already starting to throw out some medication related questions. So for those of you just joining, if you have any questions related to psych meds, she's not going to answer anything too personal, but we'll just talk general like we always do. So yeah, if you all have any questions, throw them out. Someone's already saying they hate their Wellbutrin. Um,
Wow.
it's a very controversial medic. It's like a love or hate, with Wellbutrin.
Yeah, I guess so. I guess it's either you love it or you like it works or it doesn't,
Kind of like
and
all
that's
psych
okay.
meds, right? They work or they don't, and that's what like so many people ask me about them, and I tell people like, look, I know more about meds than your average human, as I responsibly should.
Yeah,
But people have med questions all the time, and I'm just going to keep sending them over to you. But yeah, I mean, when people ask these questions, they'll say like, "Oh, I hate this med," or "This med is terrible." I'm like, "Look, no med is really good, bad, terrible. Just human beings. Our makeups are so unique in many ways, especially our brains, our chemistry. Everyone's different, and for the same reasons why we have different mental health disorders, different personalities. Obviously we're all humans, but there's still a lot of variation, and everyone reacts to meds differently. So it's hard. People want me to be like, "Oh yeah, Motrigine sucks," and but it
yeah.
doesn't really work like that.
Yeah, there's no one size fits all. So if something works for you, that's great. And it might not work for somebody else the same way. But that's why there's so many. We have so many options, to try again.
Yeah, and it's like for a psychiatrist, nurse practitioner, another med provider, I tell clients, when I'm recommending them do meds, like they're kind of shooting in the dark. Um, I mean, there are some technologies, new ways. We'll talk about that maybe a little later on, like gene site testing of ways that med providers can get a little bit more of a precise um, idea. I mean, not precise, but they just get a better idea of what may work well versus them just. I know a lot of med providers are like, oh, generally I start people on this med, but like, what other tools do they have? Like, what works for your mom? That's really all they have, and it's trial or error. And I think unfortunately, with that trial or error, I mean, we're tampering with folks' brain chemistry, and sometimes it works well, and sometimes it doesn't. And the times it doesn't, whether there's side effects, it doesn't work, or they end up in the hospital or something, then they get turned off from meds and they're not really willing to try other options.
So true, so true. Happens all the time, especially with doctors who have like their favorite type of like their favorite meds to use, you know. So it may not be the best for everybody.
For sure. Well, you're one of the few people that could put checks on doctors. So I'm really interested to hear more, and we'll talk about this a little later as well about being a pharmacist. So why don't we just start here? Like, who are you, and what is it that what's your day job outside of the content you create?
I am a pharmacist. I work in a like inpatient psych hospital, like behavioral health. Um, yeah, that's what I do. um,
So that's interesting because I've worked in psych hospitals and behavioral health, and
yeah,
I don't know if they've ever really had their own pharmacy. It's like the hospital pharmacy.
yeah, yeah. So yeah, but we're like only psych. Like we're like only psych. Like pretty much, you know what I mean? Like we don't have like I mean we have like a PICU and geriatrics, but
Sure.
it's not like a general like university hospital.
Oh, okay. Oh,
It's
that's
just for
that's
like acute, like it's for somebody who has like who's acutely like psychotic, and
sure.
then we stabilize them and hopefully send them home. So
Yeah, yeah. I mean, for
yeah,
behavioral health, and for those who don't know much about it, I mean, a lot of folks here maybe have been to a psych unit, but it's when it's a locked inpatient psych unit, it's all about stabilization, and you're usually not there for too long. Especially when
right.
you're taking someone's rights away. You're in a locked unit. It's all about kind of triage and referral.
Yeah. So like an average stay is like 3 to 5 days. And I don't know if anybody's rights are taken though.
Oh, is
Everything
it a
is
locked unit?
a lot.
Yeah, is the
Like
unit locked?
yeah, yeah.
So
Yeah.
some rights are taken. You can't just walk out the door, head to McDonald's, and come back.
Yeah, that's true. That's true. But then there's like methods for like if you really
Sure.
want to go home and stuff.
For sure. Yeah. And yeah, so I mean you do obviously have rights, but it's a big deal is what I'm trying to say, when especially when I try to get folks admitted, maybe who are having like psychosis or anything else, like, it's hard for folks because um well, for one, it's not always easy to get someone admitted. They have to meet some pretty stringent criteria um, in order because because you are essentially getting some of your rights taken away. When you're on that 72-hour hold. I mean, most people when they come in, they're on a 72-hour hold, and they could request to leave, but that is up to the doctor. It's not on their own volition, right?
Yeah, so true. So true. Yeah. Yeah, so true. But it's all good. Like
It's all good.
yeah. Yeah, plus it's hard to get a bed nowadays. So there's like if you go to the ER, you could be waiting in the ER until there's a bed.
Hmm. Yeah, no, absolutely. Right now, so are you finding that right now and at your workplace at the locked unit that like since COVID, it's been much more difficult to get a bed and folks even just to get therapy, they're finding it's much harder.
Yeah, for sure, for sure. Yeah, for sure. And then that causes some frustration, which is, you know, I don't blame anybody,
Yeah,
because then you could
yeah,
be in an ER for too long.
for sure. So that's where you work. You're in a behavioral health unit. Okay, so all right, here's what I know. Let's hear about Haley. Who's Haley growing up? How did you get to where you're at?
Um,
You intrigue me.
I, I,
I want to know everything.
I, I, I'm 28, so yeah, I'm 28. I did my undergrad in chemistry with a concentration in biochemistry, whatever that is. Exactly.
I don't
Yeah,
know.
yeah, it was a concentration. Okay. And I wanted to go into health, like medicine, but I didn't want to be a nurse. My mom's a nurse. So I didn't want to do that. And then I didn't want to go to school for a long, 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 long time. So I didn't opt to be like a medical doctor. So that's why I went to pharmacy school.
For sure. Did you know anyone who was a pharmacist?
No, no. I was never even a tech either. I was never like a pharmacy tech.
For sure, you just jumped right in.
Yeah, yeah. I just jumped right in. I was just like, um, and I always wanted to do hospital. So uh yeah, I worked in school. Like when I was like I wasn't like, I worked while going to pharmacy school, but I worked in the ER. So I was like an ER, but I wasn't really a tech. I just did like med histories in a
Yeah,
in a separate hospital.
for sure. And so, on TikTok and maybe other handles, you're our psych pharmacist. And again, that's what, super interesting. I've been in the field for a while. I mean, I have all sorts of different roles and administration, and I'm like, I've never heard of a pharmacist, specialize in psych. So how did that come about? Was it just the job you happened to get at that hospital and then that piqued your interest? Did you have an interest in that before?
I was a student. I had a rotation at my hospital, and then they kept me. I really liked it there. It was my favorite rotation, so I was interested in it.
So
Yeah,
that piqued your interest in mental health then?
yeah, yeah. I was the only student too, so I was the only student.
Very cool.
Yeah, they had, and then they liked me. So for some reason, like weird.
Strange. I wonder why.
Yeah, and then that's how. But as for like beforehand, mental health, honestly, not. I wasn't like focused on it completely, but like I always wanted to do a hospital, so that's how that kind of happened. It kind of just like happened. It literally just like happened.
Yeah, you just fell into it. A lot of people
Yeah,
fall into it, and I know you maybe wouldn't have guessed 5 years before that you'd be where you're at or interested in what you're interested in.
Right, right. But I love this job. It's the best job in the world. So, and I never ever want to leave ever.
Really?
It's a good, yeah, ever, never ever want to leave.
So awesome. I wonder what that feels like. I mean, I'm so all over. Like, I can't do the same thing for more than like a little bit before I'm like, all right, what next? But you're like, this
Yeah.
is what I want. You found it. That's awesome.
Oh, yeah, forever. I mean, I do a lot of other things at work too. Like I don't know if you haven't heard of like a psych pharmacist, you might not heard of informatics. I do informatics too.
What is that?
So it's like I basically code. So I can code. I like use like a SQL database and I make like our system that like, our like EHR because our hospital isn't that I'm sorry, it's just a zooming in thing.
I'm
Our
used to it.
hospital
I'm
isn't,
laughing on the inside with that one.
yeah. Our hospital, we don't have like Epic, like the nicest stuff. So we have like what we have, and it's not bad. I mean, but yeah, that's what I do. I like code that system.
So you're not only a pharmacist, but you're like doing coding for them.
Yeah.
You're like a
And
computer engineer.
I kind of do it at the same time. Like, yeah. So it's like I'm never doing the same thing every day. Like I'm always doing
Well, I
something,
mean, did you know you'd be doing that going in? They're like job description: pharmacist, computer engineer, software engineer.
That kind of just happened too. So like actually it like happened through so like last year around this time, our hospital system got like majorly hacked. But it wasn't just our hospital, it was like our like, big hospital. It was like 400 hospitals that got like hacked and lost computers for a month. And then like a full month. But in 2 weeks, we were able to get some computer function back. And then that's how I like started doing informatics because like in those 2 weeks, I got something set up and then and yeah, and it was like, oh wow. And then it just became part of my, you know, daily responsibilities. That was really stressful. I'll never forget that. And it was last year around this time. I remember it was September 28th of last year. It was very stressful.
Wow. Was it like a ransomware attack?
Yeah, I think so. Like
Did your
it was
hospital
it was
pay the ransom for all the?
no, we didn't pay the ransom. None of the hospitals did because if you pay the ransom, it shows to other like hackers that you pay the ransom, so you'll get hacked
So did you
again.
just lose all the data?
No, we actually didn't. Some, not my hospital, but I know one hospital did, but not mine. Uh, I know at least one like lost a lot of stuff, but
That's
we didn't. We didn't. Yeah. But yeah, so that's what else I do too. So I don't only do the psych part, I also do the informatics part.
okay. So very cool. Okay, so the big question and I feel like not many people know this. What does a pharmacist do? What is a pharmacist? Because I think there's
um,
like kind of misconceptions, like where you guys just like fill meds. It's like doctor
yeah,
prescribes, then you take them, put them in bottles. But I mean, you do a lot of training. I mean,
yeah.
it's they don't just give away pharmacy degrees. Like, so what does a pharmacist do? And I guess what is the training that brought you to that?
Well, yeah, you're right. We do a lot. So feel like I don't put pills in bottles at all, like zero. The techs do that.
Okay.
We basically just like we feel like we're like the center of the team. Like, okay, like for example, we work with psychiatrists, physicians, and especially in like a hospital, like, every patient has a psychiatrist, so that focuses on the mental health, and then they have a medical doctor that focuses on like, so they have diabetes,
Sure.
hypertension, and they do their meds, and the psychiatrist does their meds, and we're kind of the one in between that make sure, those, meds are good to go, they're good to go. We kind of are like the connection between
Mhm.
those two specialties. We titrate everything. So we're the ones that, titrate all the meds up or down. We recommend those kind of titrations. So
Okay,
like in
so
a
the
hospital,
doctor use you as a resource if they're like, hey, I want this person to start coming off, you'll prescribe almost the schedule. Is that
um, well, we'll talk. We don't really prescribe, but like we'll the doctor will ask us like, what's the best way we can, taper off this med, taper up this med. And then we'll yeah, that's what we'll do. Like we'll taper them up slow or down. Sometimes, we dose certain things like antibiotics and anticoagulants. Those are basically what we do. Yeah, catch a lot of drug interactions, make sure those are okay. We monitor.
so your job is
um
to know, you got to know these drugs inside and out and how they affect the body and what's like best practices. There's so many meds and it's probably hard to know that. If you're a doctor, like, their training, they have all sorts of training, as far as biology, all sorts of because even a psychiatrist, probably primarily what they're learning is just like, what all doctors learn. And then you do a specialty, but it seems like all your training is all centered on medications and how they affect the body.
well, it's kind of funny you say that because I feel like in pharmacy school, it's like pharmacy school is very bougie. Like, for example, yeah, like they like to pretend. So, pharmacy school is a professional school. So, it's a professional school, which means that you have to do a million different things. So, like in school, they basically act like pharmacists are the only healthcare providers that exist. And they'll make you do like these round robins, or that's what I always call them, but they're like called sim centers or like simulations. But it's where you have to do every single thing that all the other healthcare, like Grey's Anatomy, how like in Grey's Anatomy, there's the doctor and he does everything,
Yeah.
but that's not really how it is. Yeah, that's what they would make us do. So they did teach us, they teach us what everybody does. Like nurses, we had to program IVs, we had to write soap notes like medical doctors, but I've never written a soap note in my life. To this
Someone
day.
actually, someone hopped
Yeah.
on our live stream here and they said they're a pharmacist that just, or they said, my job, corporate advisor for regulatory affairs. I don't know, maybe this is for them specifically, or that's another kind of role that people fall into.
Yeah. So it sounds like that's it was like a industry, like, you go into the industry. It's like a fellowship route. You become a fellow at like any kind of like drug company or like a advertising thing. So it's like like a drug development company, and they are, what were they again?
Said, well, then they said in a PBM. What does that mean?
Oh, pharmacy benefit manager. That's cool.
That's cool.
That's a cool job. Yeah, I bet that's a nice job. I bet it's like a nice office job. So those pharmacy benefit managers, they kind of have to do with insurance a little bit, and they, you
Okay.
know, yeah. Some people don't like PBMs, but as for the
Because they're
job,
looking for the
it's a
man.
nice job, I'm sure. Yeah,
Yeah, it's like
but
sometimes
yeah,
therapists, they could work for insurance companies and it's like they're working for the
right.
man, right?
Yeah, nurses do, doctors do, I'm sure.
Yeah, for sure. They have all that. That's super. And so
Yeah,
as a pharmacist, you go into pharmacy, so there's other things you could do than just be a pharmacist working at Walgreens or a hospital.
yeah. You can do a lot of different stuff. So you could do, you could go and do R&D, like research and development. You could go into the insurance route. You could go into drug development. And I know this one guy at my work who does commercials. So he does like, he makes sure those like drug commercials follow the laws.
Oh, yeah.
Yeah, I bet
Legal
that's a cool
advisor.
job.
Like it's like the guy who's like formerly in the mob and he like, they hire him to be on a mob movie to make sure it's accurate. Kind of like,
Yeah, like when they're like dancing in the forest and they're like, this may cause, nausea, vomiting, diarrhea, and then he's like
yeah.
golfing. Yeah.
Oh, for sure. Okay, that's cool. So how many years of school is like if someone wanted to be a pharmacist, what do they have to do?
it's usually like 4 years undergrad, 4 years of school. But some schools are they're like dual. So you go 2 years undergrad, 4 years of school, 4 years of grad school. So 2 years undergrad, 4 years of grad school. And it's like a dual acceptance. So it could go anywhere between like 6 and 8 years. And then there's postgraduate. So then you could do postgraduate stuff like fellowships or residencies. Those usually last 1 to 2 years. So it could be a long time.
Yeah. Yeah, like I said, they just don't give those away. Is it considered a master's level, a doctor? It's just like its own thing, like being a lawyer or something. It's like,
It's a doctor of pharmacy. So so you're a doctor of pharmacy, but you're not a medical doctor. So
is it a PhD
yeah,
or it's its own like letters?
it's not a PhD. It's a PharmD, but so I guess that's different. Yeah.
Yeah.
Like a lawyer. I don't know what a lawyer is. But
J.
yeah, it's not a PhD.
Julius Doctor or
It's
something.
it's not a medical doctor, but we're still doctors. And so we're still doctors. Uh we have that, doctor in front of our name.
So when you make like reservations at a restaurant, do you say Dr. Haley?
No, but it's funny because
That's the only reason
I've
why
actually,
I would want.
what?
I'm sorry. That's the only reason why I'd want to get my doctorate, so I can make reservations.
So actually, I gotta find it, but actually, I like to play ping pong, like weirdly. Because actually, me and my friends in school, we would play ping pong during all nighters, and I joined a like ping pong like Team USA, Team USA, for like to be ranked and as a player.
Like
Yeah,
professional,
and
like professional ping pong.
I don't know if I don't know if it's I guess it's as professional as you want to make it, but like you could just do it casually and just, go to competitions and get ranked.
Okay.
It's just a national ranking, basically. Yeah. And I joined it, and then I gotta find my little, because you get a little card and in the mail, so that you can go to these competitions. And I called myself Dr. Haley, just because I thought that would be really like ridiculous.
Yeah. Dr. Haley,
Yeah.
pharmacist, ping pong pro.
Yeah.
You're like
Yeah.
Prince. Prince loved ping pong.
Your parents?
Prince, the musical
Prince?
artist from Minnesota.
Oh, wow. It's fun. It's a fun hobby.
That's awesome. Okay, so that's how you become a pharmacist. So we talked about, I was wondering how you get utilized in the healthcare team. Let's see. So, okay, so that's being a pharmacist. Now, whenever someone's on here, who most everyone has is a content creator of some way, how did you get into getting on TikTok? What prompted that?
I started making keto videos. So I was doing the keto diet. I still am keto diet.
Yeah.
And and then I was making videos, and then mostly on Instagram, but also here on TikTok. And then I would like post little TikToks that I made to my Instagram stories, and some people liked them. So that were more like about meds, and I'm more about like, just my work and just working and stuff like that. People liked them. So then I moved. I'm like, how would I just post some of these? Actually, like, because I would only post in my story. So I was like, people like them. So how would I just post them?
For sure. Okay, so you did that, and then you noticed, like, hey, people are interested in this content, and they kind of directed you to.
Yeah,
Yeah.
for sure. Like, that's what happened. So it was kind of cool. I like posting more about like work and med stuff more than keto. And I love keto, but I like posting about meds and stuff, because I feel like keto is like a very controversial diet, and I had no idea, like when I started posting about it, I had no idea it was so controversial. So now I post more about meds, which are just, these are just facts. This is how the med works. This is the structure of the med, and feel like it's it could be it's some people like it, like some people find it valuable.
Yeah.
Yeah. So yeah.
Yeah. So I ask folks this too, for myself, starting to post and interacting with, the general public, not just my clients, patients, whatever, it, I kind of, I learned a lot about, people and what they want to learn about, what their questions. You start to get some of the same questions, you get some of the same comments, feedback. It's like, what have you learned from creating content as far as, people's perceptions, or what do they want to know? Like, what are the more common questions you get about medications? And
Yeah, that's a good question. Yeah. So the main thing I learned was about SSRI withdrawal. Um, so that's like the main thing I learned, which I was very shocked about. So I had no idea that people had really bad withdrawals. They could have, really bad withdrawals from them. And it just really piqued, it's crazy because in the hospital, you may show up, with an acute, like depressive episode, but, we could be um, not seeing that, oh, they're actually withdrawing from an SSRI, you know what I'm saying, or SNRI. And I had no idea it was so bad. And well, for some people, not everyone has the withdrawal, but some people do. And yeah, and it's just interesting to me because in school they did not teach us this. So it's like almost like a conspiracy. Yeah, it's almost like a conspiracy because they teach us that you could have withdrawal, but nothing like nothing like the comments that I get about people's so that's why I think they're prescribed so much, because the doctors weren't like taught this either, that the withdrawal is so bad, and it's really downplayed in the literature. So the literature always says that there's, there's a mild chance to get withdrawal and it'll, resolve in a few weeks. But then on TikTok, I'm seeing that it's like way more. And these meds were thought of as harmless, but I don't think, that's
yeah,
accurate.
that's super interesting that they downplay, because I noticed that as well. We have some crossover, and people ask me that with meds, and I, being an addiction specialist, withdrawals part of the game. With alcohol and benzos, and it's very no. I mean, it's a symptom of a use disorder. Folks who go into withdrawal, just one of the symptoms, but. So I've done some postings on that, and like one of the bigger postings I did was I called it, actually, this funny, but it was like strange withdrawals, I called it. Right. So like, here's
Yeah.
some things that you may not know that give you withdrawals. And one of them, like coffee, Afrin, like nose spray. And then one of them I did was Effexor, and all of them do it. But I've always heard from people that they get just, and I may have learned this just from people on TikTok, that they get like horrific withdrawals from Effexor. Like they call it like
Yeah.
brain zaps, and I don't even know what the hell that means, but everyone's like, "Oh, I get the brain zaps," and and some of the addiction clients have said it's just as bad as coming off other drugs.
Yeah. But the thing is, like, compared to addiction, so like SSRIs are and SNRIs, they're not really addictive, as you know, they're like, but
Yeah,
you still get that withdrawal. Like, and the
that's right.
problem, what was that?
Dependence. You may not be,
Yeah. Yeah.
which is like
And the
a form of
problem,
addiction, but in and of itself, like a lot of people, let's say maybe they don't have that. I don't even know how to like. Some people call it like psychological dependence, addiction, but I would almost call it like an emotional attachment in some ways, right? Where it's like you're not like looking forward to taking your SSRI because it's going to have an immediate effect, a pleasurable reward effect, like other addictive substances, but you have that same level of dependence, like you would an opiate. And that's what I've learned is like if you take any substance, your cat.
my
Oh my
kitty.
god, that's so funny. For those of you just tuning in the podcast, Haley's cat just came on the desk, and the cat's butt is like right in her face.
She wants attention.
Yeah, but yeah, so with with brain chemistry, when you're tampering with brain chemistry, but also even meds that are more physical, right? Our bodies adapt, and when you're on something for long enough, I think it's more common than not that you're going to have some withdrawal symptoms, or I'll just even refer to them as rebound effects.
Yeah, yeah, for sure, for sure. Yeah, your brain chemistry does change. Receptors upregulate, downregulate. A lot of stuff happens after even short-term use of SSRIs and not even long-term use. I've been researching a lot about it, but yeah, so basically your serotonin receptors can, increase or decrease, and then the density of the receptors change in different parts of your brain. And that's what kind of causes those, effects. Which the only problem, like the main problem I have about it is that there was this one study that showed that only 1% of people were recalled their doctor telling them about the possibility of withdrawal. So only 1% of people. And that's my main issue with it, is just the fact that if you want to go on a med, that's perfectly fine. But are people being told, hey, it could cause some withdrawal?
Yeah, it's absolutely crazy. And I think that's like a big ethical and informed consent. I mean, we're telling people to get, and I'm not a med provider, but I refer a lot of people to take meds. And, as a provider, like of any service that I'm providing as a therapist, I mean, same thing goes with a doctor. You have to have that informed consent. Here are the risks and benefits. And people aren't properly informed of the risks. And maybe you could attest to this, but only a small percentage of people actually take their meds as prescribed. Um,
Yeah.
it's like any other habit. It's like if I told you to floss every day, only so many people do that. And so they don't realize, it's like I've done that. I forget to take my meds for a few days and I'm like, oh my God, I feel crappy. What? Oh, I forgot to take them. And people don't know what's going on. And they start to feel horrible. And, because not everyone, let's say, quote, responsibly, that they say, okay, I don't like the side effects of this med. Oh, I think I'm doing better. And then they just stop taking it. Then they're like, whoa, and they don't understand what's going on, and they don't understand, too. They, for all they know, this could last forever.
Right. Yeah. Yeah,
I have
for
my
sure, for sure. And that's where her name is Buggy.
bug. Oh,
Yeah, she's a bad baby. But that's where pharmacists can be a big help too, is like stressing those medication adherence, possible side effects, how to take meds, like with food or without food, just making sure the patient feels empowered. And I want people to be the master of their medications. I want them to know everything they want to know. Because I feel like if I was a patient, that's what I would want to know.
for
I
sure.
want to know everything. Yeah.
I mean, and especially that. I mean, that's huge. I mean, what being in withdrawal could be a nightmare. And
Yeah.
I mean, I would venture that it is more common than not if you are on a psych med like an SSRI, SNR, whatever, for a long period of time, that you're going to have some rebound effects, if not be within like full withdrawal.
Yeah, absolutely, absolutely. Even other meds too, like even antipsychotics can cause withdrawal.
Any of like really any of the psych meds, Motrigine, I
Yeah,
mean, all the different compounds. I mean, because you know, and essentially, I mean, that may be a good sign in the fact that you like, if it's working, if it's actually doing something for you, when you get off of it, it is no longer doing that thing. And your brain's like,
yeah,
whoa, where's my little helper here? And then the withdrawals, like your brain's like overwhelmed of like, whoa, I'm not used to, I haven't had to do this for a while. Um,
yeah,
and then it has to readjust without that assistance, and then it throws
yeah,
off your brain, and you feel it in your body. um, Substances, like something like an opiate, right? You don't think of it as being something to regulate your temperature, but it does, right? So then when people get off of it, they're hot, they're cold, and they're like, what the hell is going on?
yeah, for sure, for sure. Especially with the brain, you know, they have all the circuits, like all the brain circuits overlap. And right now in psych, a lot of the meds are thought to work on, one system, like the dopamine system in the
Yep.
mesolimbic pathway, when really, those neurons innervate other neurons. So in many other neurons downstream. So they have a lot more effects than just like what we're kind of seeing them as like currently. I mean, of course, there's research and stuff, but they have downstream effects. Like, for example, serotonin can be activating, right? So serotonin is activating. But if it works on a GABA neuron, a GABA neuron is inhibitory. So we got this activating serotonin neuron working on an inhibitory GABA neuron, which would increase dopamine down the line because nothing's putting the brakes on the dopamine, and increases norepinephrine down the line because nothing's putting the brakes on norepinephrine because the serotonin is activating the GABA neuron, which inhibits it. You see what I mean? So it's like very, very complex. Yeah.
Yeah, it is very complex. And as you're saying, I wonder, like, would your average doctor be able to tell me that? What you
Um,
just told me, if we
um,
quiz them,
okay. Like a medical doctor, like that's just like a
psych
physician, like a family doctor.
psychiatrist, NP, like a
Okay, a psychiatrist. Like I believe, like a lot of the doctors in my hospital, we talk about this stuff a lot, so I feel like they would be able to tell
hopefully
you
know
that.
that.
Yeah, but like I don't know too much about like a medical doctor. I don't know if they would be able to tell you that. Just
No,
like because
probably
they're
not.
like mostly focused. Yeah,
Yeah.
they're focused on other stuff. So
Okay.
like yeah, like blood pressure and all the other stuff they do. They do so much stuff. So they're focused on all of that more than like the
Yeah.
very specific details.
I was just more curious of the people who usually prescribe them, know to that detail, like what three steps ahead. I mean, I know they have to, obviously know a ton about it, but I mean, you start to get really complicated, and again, everyone reacts so differently to different medications. Um, but to shift a little bit, why are meds so important, or do you think meds are like super important as part of the care of somebody getting mental health services?
Yeah, I think meds should be, last line to lifestyle, like let's work on lifestyles. I think meds are a tool. Um, yeah, so I think meds are really a tool. So like say you come in and you have like a acute, like, severe depressive episode. Let's put you, we could give you a med, and while you're taking this med and you're starting to feel better, maybe you could use this time to like start working on your lifestyle. So you exercise, you do things that make you happy, go outside, whatever makes you happy, get in routines, get enough sleep, use the med as a tool, and then hopefully we can like start thinking about maybe coming off the med when you get your habits down, stuff like that. If you want, like if it's all individual. So if that's what the patient wants to do, great. Yeah, so I think meds are really a tool to help us while we, adjust our lifestyle, eat healthier, all that. They
Yeah,
don't have to be long term.
yeah. In my experience, yeah, well, there's so much we could get into, but I think there's a lot of stigma and misconceptions around meds, and a lot of general attitudes of, it's not natural, and we should try everything first. And the way I look at it, I have, let's say I have a therapy client for the first time I'm seeing them. Maybe they haven't really had much therapy. They're experiencing depression, anxiety, right? Most commonly, or other disorders, right? And so let's just say your average depression, anxiety, stress kind of person comes in, as part of the treatment plan as a therapist, I'll diagnose, and if it's their first time trying anything, I'll say, all right, hey, here's part of our treatment plan. We're going to look at some of the lifestyle changes. We're going to remove some of the stressors, maybe work on some of your relationships, process your emotions, trauma. And look, and if that's still, and after a few months, if you're still struggling, maybe meds could be a good tool, like a helper for me as the therapist to kick them into a better, mindset or brain cycle. And I tell folks, you don't have to be on meds forever. Sometimes it can be like training wheels. At least that's how I look at it. And then responsibly titrate off of them with your
If they
doctor.
want. Yeah, if they want. Yeah.
Well,
If they're comfortable with that.
people don't always know what they want, because they're not informed.
Yeah.
You know what I mean? Where it's like, okay, do I want that? What do I get? What are the benefits of meds? And so I think it's what's really important as therapists is often we're the first line and we're the ones who are referring. And in my experience, therapists, your average therapist doesn't know a ton about meds, and they don't teach us that in school. And I think it is crucial that we know about meds. I mean, usually we learn through experience, and we probably take a psychopharm class here or there, right? But I think it's really crucial because we're often the ones referring people for meds.
Yeah. Yeah. Right. Right. For sure. For sure. Same thing with doctors, though. I feel like a lot of their like med knowledge is through experience versus through school.
That's scary. I think that you do, but especially for a psychiatrist, because that's your primary duty, right? Is
The same thing.
yeah. What are they learning? Like, all right, here's how to do CPR. It's like, okay, well, that's good, but
Well, see, yeah. Like I went to in my pharmacy school, we also had a med school. So we got to like go to a lot of classes with them. And yeah, I saw we learn, everything about meds inside and out, every little thing on every little structure, we know what it does, every little enzyme it reacts with, we know that. But I feel like doctors are more, they spend 2 years in school and then they go on rotations where they learn a lot of things,
sure.
On the job and on rotations. And then they go into residencies that last a long time.
Yeah, I mean, they're
Depending.
well
Yeah.
trained. It just well, and sometimes it's interesting as a therapist, right, who's not well trained in these things. That's why it's so important to know because they're going to go see their psychiatrist, get put on a med, and maybe a good psychiatrist will have them follow up. All right, come see me in 2 weeks. Let's see how it's going. See you in 4. But then after that, it's like 6 months, and
Yeah.
but I'm seeing them almost every week, and it's like I need to know this stuff because sometimes getting on, let's say, a new SSRI, I mean, some people have really bad reactions and has like the opposite effect where they become really depressed or suicidal. And, but they don't realize it's the meds. And
Yeah.
they're like, oh, no, my life is horrible and things are always going to be terrible and I want to end it. It's just completely different from how they normally feel, but they don't realize that this is just a bad medication interaction. And then it's important for therapists to kind of, be like a backup and catch those
Yeah.
so that a psychiatrist may not. I mean, the responsible, a psychiatrist would say, hey, if you're feeling any of these symptoms, right, give me a call. But maybe that doesn't happen all the time. Just like with the med withdrawals, maybe the informed consent isn't always there among every provider. What's your experience with that?
Well, like psych NPs, I love them. I love those people so much. They call me all the time. And yeah, and they always ask questions. As for like outpatient people calling me, like it seems like you do a lot of like outpatient, like, one-on-ones, stuff like that.
Mhm.
And you also worked in hospitals before. Yeah, those I don't really get calls from that, but in the hospital, like, I have nurse practitioners call me all the time, ask questions, stuff like that.
You. Right. Or our doctor's just like, I know it all, so I don't want to ask it for help.
No, they're great too. They call all the time. Oh my God. I feel like so many people on TikTok like to say something like they like to comment on my voice. Okay. Sometimes they'll be like, oh, you have an accent, or they'll be like, oh, you sound tired. And it's like, I was just on the phone all day long talking. Yeah. Yeah.
Exhausting. So, I mean, in what ways, is a pharmacist integral in that care process? Like, it sounds like you do a lot of like education with some of the med providers. You have this like more deep, intricate knowledge, like specifically geared towards meds. I mean, do you ever have, how often does it happen? Maybe not at your work or just in general. We don't need to call out your place of employment, but where like a doctor maybe prescribes something and then it goes through you, right? And you're like, whoa, wait a minute, there's an interaction here with this medication that is contraindicated, and
Uh,
you have to kind of put a check on that.
all every day. That how often? Every day. Yeah, every single day. Pretty much multiple times per
Like,
day.
yeah, I'm gonna throw them on this, and you're like, no, they could die. So we may, you call them, be like,
Well,
hey, we don't want to kill this patient. They're like, oh, sorry.
okay, kill, like I don't like to go that
Not
far.
kill, but put them at risk
Yeah,
of harm in some way, shape, or
yeah, for some undesirable, side effect. Yeah, that happens every day. But doctors are, they're really receptive, and they value that. They're like, oh, thank you, thanks for seeing that.
form.
Especially when you got two different doctors at the same time, like a medical doctor and a psychiatrist.
Sure.
You got two different of them, so they don't always, like say they both put in an order at the same time or something. You know what I'm saying?
So that's why a
So
pharmacist is like super important. Like,
yeah. Oh yeah. Thank you. And yeah, there's so many things too. Like even at the rate of certain titrations, like if you titrate up, risperidol too fast, it can kind of act like a first generation antipsychotic versus a second gen. You know what I'm saying? So like if you titrate up too fast or too slow, different, you get different effects. Meds at different doses, can do different things, Um, so yeah, we're really, it's like our part is to to help out in that way.
and this happened to a friend pretty recently. I mean, she was on, and I think that goes to the like physical, more, physician, but physical health, mental health doc, where there's not always the communication, or, like I had a friend who was on a certain medication for physical health, let's say, and then she got her med adjusted, or it could have been the opposite way. She was on a psych med and then the doctor put her on this, or it was one or the other, but then she got like serotonin syndrome and wound up in the hospital, and then later found out like, no, that was a big no-no. Like that doctor should not have put me on that. It's not like hidden knowledge. This is a known interaction. And she wound up in the hospital.
Oh wow, that super sucks. That super sucks. That's really too bad.
But that's not
Um,
uncommon, is it? I mean, it seems like, from what you're saying, like, because maybe not everyone has the stopgap of a pharmacist. So should the pharmacist have picked up on that? Like,
um,
who's to blame?
yeah, that's a good question. Who's to blame? Well, they were outpatient, right? Outpatient.
Yeah, yeah.
Um, I don't know, honestly. I'm not sure who's to blame, but like, you know, I've never seen serotonin syndrome actually, like luckily,
All right.
I've never actually seen it in, my practice, but as for like an outpatient setting, there's many, it's different. Like, so for example, in my hospital, you spend a lot more time being able to look at med therapies, optimize them, make sure there's no interactions, look at labs, make sure the med is right for the patient, 100%, so we have more time per, script or per order or whatever. But like if you're talking about like at a Walgreens or something, it's kind of a different, they would like, it's kind of different in that kind of scenario.
Are they double check?
Where
Is that like what a pharmacist, they say, okay, hey, this client just got an order, and then do they know? I mean, they know the other meds they're on. Maybe it's in the system.
Yeah, that too, polypharmacy, or they could be filling in other places.
Yeah. And are there like alerts that come up? Like probably nowadays with technology, right? If it's known a client, like at Walgreens, even if they know a client is on this, and then all of a sudden another prescriber this comes into the system, like, whoa, these two things are
The alerts that come up are useless.
okay.
Yeah, there are 1,000 alerts. They will flag everything. So, yeah, they're pretty much useless. You really got to use your own brain there. Because if you just relied on alerts, like, I mean, maybe some hospitals are more, or like some other things are more sophisticated, like, but yeah, basically it's universal that all the alerts are pretty useless. They flag everything. They flag everything.
Yeah, okay. It's a little sensitive
Same
alarm.
thing with serotonin syndrome. Like for example,
Can I stop you real quick? Someone is actually asking here. Can you explain what serotonin syndrome is? One of our followers here.
so it's basically it's really unpleasant. It's very unpleasant. It can have a lot of symptoms like rash, itchiness, chills, fever. Even it's caused from all these meds that interact with or increase serotonin, and usually it's not a concern if they're on one or two, but when you start adding them on, it can kind of get more serious.
So, how many, I don't know if you know this number, it's kind of a crazy question. How many medication, pharmaceuticals can a doctor prescribe? Like, I mean, and I mean like literally, like how many medications do we have? Like, do you know that number?
No, like the total number of
Yeah,
medications.
yeah.
Oh, no, I don't know.
So let's say it's 10,000. Is that,
Okay.
maybe that's a little high? Is that
Um,
like different
I don't
meds
know.
that pharmaceutical companies make for, you know,
Let me see if I can look it up because now I'm actually curious.
so okay, let's just say it's 5,000, but if you pool every pharmaceutical company and the drugs that they produce that a physician somewhere in the world can prescribe, let's say it's 5,000, right?
20,000.
20?
There's
Oh,
over
okay, I
there
was
are
close.
over 20,000 prescription drug products approved for marketing.
So I wasn't horribly off at 10. I mean, it was
Right.
50%, but it could be,
Yeah, you were close. You were very close.
I'd say I'll pat myself on the back on that one. But so 20,000,
Yeah.
a lot of it, that's a lot of interactions. And not only could that be two drugs, what if there's three drugs? It's like, all right, you combine these four and it's dangerous. How the hell how the hell do you keep track of that in your head?
Um, that's a good question. Well, okay,
The hard
like
pressing questions here.
yeah, that's a good question. A lot of meds are like meds that are part of similar classes, and they will kind of do similar things. So, there's different pearls and every med is different, but um you can kind of almost like guess at a certain point and be right, like about it. Like if you think, like if you get spidey senses, like spidey senses,
Yeah.
and they go off, you're probably right. And there might be an interaction there. I personally, I don't know if a lot of other pharmacists do, but I look at structures. So I can tell by looking at different structures. So if some random med comes in that I don't know what it is, I'll look at the structure and be like, okay.
Okay. Well, yeah.
Yeah. I don't know if other people do that though. I guess I'm very visual.
I just can't wrap my head around, like, with so many drugs and interactions and possible side effects, like how does one provider, I mean, maybe you have a database that you could look up and you got Google now.
Oh yeah. Yeah, we have there's LexiComp and Micromedics, and there's databases that help a lot too as well. Yeah, and also I like to look the package inserts and stuff like that. You could look at package inserts. You could do research online, read some studies.
Okay. One of my
Yeah.
followers here said, I don't know, maybe you've heard of this. I was told I have ophthalmia. three separate points in life. It's a high level of serotonin and oxytocin. Have you heard of that?
Okay.
Maybe not.
Ophthalmia?
Yeah, I don't know. I was just curious. Yeah, one of our followers said that.
Ophthalmia. It's high levels of serotonin and
No, that's what she said. Yeah, and oxytocin. She must be. You must be like really. Are you like always happy and in love? Like, I wish I had those high levels. It's like, yeah, life's great, man. I don't know what everyone's complaining about.
yeah. Here I'm looking at.
That's Miss
I'm not
Clump. So
really
Miss Clump,
seeing
are
it.
you happy and in love all the time? Is like what? How does one know that they have that?
Ophthalmia. Ophthalmia. Ophthalmia.
No, it's okay. We can move on. I was just, I don't know. She said it's like OPTHYMIA.
Um.
Just
Oh.
pretty much happy and in love all the time. That's what she said. So, well, all right, we can move on. But yeah, I was just curious. And so, for everyone who's just joining, we have Haley, your psych pharmacist. Many of you know her from TikTok. And if you don't, you need to follow her. She is a specialist, if not expert, in psych meds. And like I said
Oh.
before,
Wow.
um,
Thank you. Wow.
but no, seriously, like, who else? I mean, there's very few people who have us in pharmacy who have that specialty. Um, for you, you work in a location that pretty much solely deals with it, so you have the ability to focus on it and have the interest. But otherwise,
Yeah.
I mean, yeah. So everyone go follow. And so if you have questions about meds, and I saw some from before, feel free to post it in, and we'll ask a little bit later. So yeah, her username is your.psych.pharmacist. People are wanting to know. So
You think I should change that username?
no, I like it. It's perfect.
Yeah.
Perfect.
Okay.
I mean, I
want to.
that's
I
what I
want
say.
to change my profile. Huh?
You want to change your profile picture or something?
I think it's so bad. Like I put it ironically because it's like a picture of me with sunglasses. And it was supposed to be ironic, like a 2000s picture, like from the year 2000, like in the 2000s, like 2008 MySpace picture.
Yeah.
But now I'm like, I don't think people know that's ironic.
You just think that's
that it was.
I mean, I feel like you have to have them with your patented look, with the glasses, with the microphone, the headphone microphone hanging down. I mean, like that's you.
Yeah. But it was sunglasses and they were like pink. They're like pink sunglasses. And it's like, oh, it was like a, from like this kind of, angle.
Yep.
It's like, I got to change that.
Maybe we need a little rebranding now that you're growing your account here. So let's see what else. I don't know. Let's talk about like med stigmas. Like why do you think folks are hesitant? What are some misconceptions about meds?
Probably the name, like certain like antipsychotics. Like I hate that name. I hate that they're called that. I wish they were called something else.
That's a good
I don't
point.
know what.
Yeah.
Right?
Well, and they're prescribed for other things too. And I think people get that really confused because a lot of people take antipsychotics and they don't have psychosis, right? They may take it for sleep, or something like I think a Abilify, they use it to maybe enhance another med for depression. And then people think, oh, they're on an antipsychotic. Oh, maybe I should.
Yeah. Right.
Maybe
yeah, which sucks. That super sucks because you're right. They are like they can be used to augment depression. Some of them are used off labelly for sleep, like Seroquel. So I hate the name. We should think of a different name. I heard that they were trying to change the name for a while.
Maybe call them chill pills or.
I like that. I mean, I like that better than
antipsychotic. Like I go take my chill pills. Sounds a little better than antipsychotics.
Yeah. Your chill pills,
Pro reality.
Yeah. But yeah, that's stigma. I hope we can end it at some point. Like eventually the stigma goes away.
Yeah. Like what other stigmas are so like someone said here, like, oh, they changed their personality. Or they change
Oh,
your personality. Like, so what are some of the worries clients have due to the stigmas about getting on these meds?
yeah, there's definitely that one. But like I said before, we could just use meds as like a tool, to get somebody on track if we can, if it's like indicated. As for like changing, personality, um, most of the side effects are usually like mild,
Sure.
like, you know, sedation could be one. And a lot of patients do say that the side effects are worth it. Like the side effects of insomnia is worth having a better, quality of life.
Yeah.
Yeah. So all that stuff has to be, it's all individualized, 100%, what the patient's comfortable with.
Yeah. And that's the hard part. Like we were saying at the beginning, is it is so individual and everyone
Right.
reacts to meds completely different. And, we can't paint a broad brush, but there are some commonalities. Like for example, like with some of the SSRIs, right? They're kind of notorious for having some sexual side effects, I think for men and women. And I always like joked, I'm trying to incorporate this into a TikTok where like certain antidepressants, they put you in this weird precarious position of, do I want to be happy or do I want to have sex? And it's not an easy answer.
Well, then you can use certain other meds to like help with
Oh,
that,
okay. So yeah.
like the blue pill.
Yeah, you could do a little blue pill action. But yeah, I mean, that's a lot of the reason, right? In my experience in working with clients, and the antipsychotics is a big one because sometimes the meds that people most need are the ones that have some of the hardest side effects. So, like, I when I look at different disorders, and again, it's different for everybody because someone may not have a reasonable chance of pulling out of depression or having like a normal level of functioning without meds. Now, someone else with depression, they change up their relationships, their work, they process some trauma, and they're feeling better. They don't really need the meds, right? So certain disorders are maybe more heavy on the therapy, and even with depression, right? There's like probably hundreds, thousands of different types of depression that all express in the same way. And maybe some are more you need meds are more integral for that individual's like it's like a fingerprint. We all have fingerprints. Some look similar, but like everyone's is completely. No one has experiences depression, anxiety, whatever in the exact same way. But certain disorders in general may like so an example one that may be more med heavy would be like schizophrenia. Like there's only so much I could do as a therapist. However, it it's definitely a benefit for people to have therapy, see a psychologist, whatever, if you have schizophrenia, but not much I could do if the psychosis or if you have bipolar with psychosis, like bipolar one, we got to get the meds stabilized that, as a foundation, then we could do that kind of work.
Yeah,
Uh,
for sure.
but then, so let's say someone who has schizophrenia, someone who has bipolar one, the meds that they have to be on are often some of the ones that have the most side effects. Like weight, like let's say like risperidone or something like Seroquel, big time with weight gain, makes you
Yeah.
tired. Like they really zonk you out for some people,
Yeah.
right? I mean, eventually you get
Yeah.
used to it more, but it's a quality of life. When I mean, you mentioned that it's a like would I rather be in active psychosis or tired? But that's not always easy because you're like, I'm kind of sick of like sleeping 14 hours a day and being 50 pounds heavier. And it's tempting to get off and take your chances.
Yeah, for sure. Which is, that's really hard. That's really hard for anybody, you know. But there are things like the long actings. I don't know if you work with those or you see those much, the long actings. Those help. Those help a lot with those like, having to worry about taking med every day.
Are you
And
talking
yeah,
about
like
the shots? Like, and I was going to ask you that about that too. Like, what are we like? What's the newest and greatest technology? And that's what I'm seeing a lot of folks going for, like on my end in the addiction, like let's say for something like Suboxone, which is an opiate um, replacement medication, right, for opiate cravings, instead of, like, because some people could potentially abuse them, and there's like worries about that. But if you give someone something that's very long acting, there's less abuse potential, but then you also don't have to remember to take it as much. And like, if the same thing, if you're schizophrenic and you get a shot and it lasts for, I don't know, is it like a month, 2 months, 3 months? I mean,
Some of them are 1 month. You get it monthly. Some of them are every 3 months. One of them, the brand newest one, is an Invega, and it is Invega half-ya. And guess what that means? Half year. So it's half-ya. So so you get it every 6 months. And this one's not out yet, but it's like brand new. It's the newest one.
That's unbelievable. And I mean, I think that's a game changer. A lot of these, I think, are going to be game changers for people. Like any kind of long acting med, and it takes the human error out of it. And we said before, like, I don't know if I saw the statistic where it's like, let's say a doctor prescribes you a med. I don't know if it's different with a psych med, but it's like something like 30% of people actually take it as prescribed. I don't know what the room for error of that measurement is, but it doesn't surprise me.
Yeah.
Is that right? Or am I just making this up? I mean, I think it.
I mean, that's right. Like I don't know 100% that exact number, but yeah. So adherence to your med is it's rough. But nowadays, there's more, different formulations that can, that's what a pharmacist really does too. Like, for example, that's one of the things I do at work. I always, try to find the best like formulation for a patient. So like whether that's taking the med down from 3 times a day to twice a day or to once a day or once a week, depending on their lifestyle, how busy they are, that's really where pharmacists can help, is like helping people with adherence strategies. Lots of patients are good with adherence though. Lots of patients take their meds every day. Yeah.
Yeah. I mean, sometimes you got to take a few, beatings from life, after, and because a lot of client, they'll tell me on here, we're talking about withdrawals, which is, I think, one of the most, some of my videos on withdrawals get more views than anything else. And I think it really applies to a wider audience, or people are just more interested in it. But they'll stop taking their Effexor, notorious one, and they'll miss a couple doses, and they're like, oh my God, they had no idea that was a possibility. Well, then they learn pretty quick, I need to take it every day. Now, the scary thing is then they're like, oh, because of this, I should get off of it. So like when I did that video and I, talked a little shit on Effexor, and I did put the disclaimer, like, this is an effective med for many people. And if a client said, hey, should I get on it? I would be like, yeah, it's worth a try. It's very effective for many people. However, you just need to know, right, that informed consent, that you need to be extra careful on this one, not to miss a dose. And if you want to get off of it, you should do this with any med, but you especially should not take matters into your own hands and do a slow titration with your doctor.
Right. Yeah. Right. Exactly. That's exactly right. That's really good advice. Definitely talk to your doctor. It's great to have open communication. So that's really good that I feel like that's a really responsible thing to like tell patients, is to have, good communication about it. Like if they're feeling anything, they don't want to take it anymore, talk, let's have a conversation. You might be able to fix that.
Yeah. And, so
fix the problem.
Withdrawal, but then, some folks, like I got a friend who has thought disorder, right, who has schizoaffective, and he'll go many years, right, and he'll be doing well. And then, decide to smoke a little weed again. Deciding, hey, things are going well. Maybe I should get off my meds. And then his life falls apart. Or even just, let's say, someone who's like doing well on antidepressants, and they're like, oh, I'm good, therefore I should get off. But maybe that's one of the reasons why you're doing really well. Not that some people can't get off after they have new coping skills or in a new situation, and they, are able to get off meds, and it just helped them for that period. But that's kind of what I was saying, of like, sometimes people need to learn the hard way, take a few knocks on the head by not using them correctly or getting off too quickly, that like maybe the patients, probably have a little more experience in the psych hospital, right? They've maybe been in the system a little bit more, and so they know, um, yeah, I need to take this if I want that quality of life. Or maybe they're in the psych hospital because, I mean, how many of the patients in the psych hospital are ones that they're there because they stopped taking their meds? Probably
Yeah.
10%, or they didn't take them properly.
Yeah. Yeah. With antipsychotics, like that's a problem if you stop taking them like abruptly. It's because they're dopamine antagonists. So when you stop having that antagonist, stopping the dopamine, your dopamine can go up pretty high. So that's where that comes in.
Yeah. What's a general overview of like the common meds types and how or why they work? And I mean, and folks, you need to go check out her videos if you want to do the 500 level class. But I feel like all your videos are like
They're
500.
not that advanced though.
Yeah, they are. I mean,
That means
cool. Like, I mean, I have to pay attention. I mean, I know about this stuff. I got to pay attention to your videos. I'm like, all right, the agonist of this receptor, and it's
yeah, that's the thing. Lots of people try to ask me to explain something that's very complex, and I'm like, oh, how am I going to do
you
that?
do a
Look,
great
remember I was
job
telling
with
you
it.
earlier?
What?
Like, remember when I was telling you earlier? I'm like, all right, so like, if a serotonin neuron acts on a GABA neuron, that's gonna, decrease all this stuff downstream and versus increase. You know what I'm saying? So I'm like,
Yeah, exactly. And you really go into that, and I think you take an extremely complicated concept, and you're able to, you got your little diagrams, and you're
yeah,
showing.
make those on Canva.
Oh, you do? Oh, you make those? Okay.
Yeah, because I don't want to get in trouble for copyright. It's not worth.
TikTok, won't notice this, but yeah, I'm just kidding. Yeah, that's super. That's all the more impressive. That's awesome. You got that computer knowledge. You said earlier, so you can make a little document on Canva. That's super impressive. But
Oh,
yeah, so what
thanks.
are for folks who are needing the 100 level now? What are maybe someone who they're not on any medications, they have been hesitant, they're newer into therapy or mental health services. Like, what are some of the different major classes of meds and their
So in general, for like in total, in general, so like for
like the most
depression,
like what are the few like yeah most common meds for mental health, and why do we give those out? What do they do for you?
so a lot of doctors have their favorites, like you were talking about before. Depending on whatever's going on. Some meds, like let's say Luvox, which I want to make a video about soon, because that med is kind of cool.
Soon, Luvox.
Yeah, fluvoxamine.
Fluoxetine?
Luvox.
It's different than fluoxetine.
It's different. It's not Prozac. It's
Okay.
Luvox. It's specifically indicated for OCD, but it has like, yeah,
That's good to know. That so Luvox is for OCD, because people ask me that. What can I take for OCD? And I'm like,
it's the only one that's indicated for OCD. It's Luvox, Luvox. Yeah.
shit, this is good info for me too. So I'm saying I learn a lot from you. Yeah, someone actually asked me
Um,
that the other day. I'm like, I don't know. I mean, like antidepressant maybe to help with the anxiety, but I didn't really realize there was like an OCD specific. And people
yeah.
ask that like, well, what about for borderline personality disorder? What's the med for that? I'm like, well, I don't know, maybe like, but traditionally, no, there's nothing like specific for that in just the nature of that disorder. It's like again, you could treat, like for PTSD, treat the depressive anxiety symptoms that come from it, the nightmares. You could, there's some medications for that, but that's really interesting that we're getting more precise.
Right, exactly. Like you get more precise. And yeah, and not all drugs have like a specific, like special thing, like Luvox. Like not all drugs are like that. Like you're saying, like what's the most common thing for BPD? Well, there's not really one. It's
Yeah,
like yeah,
chill pill, different kind of chill pill.
yeah, different kind of chill pill. What else? Okay, so there's the SSRIs, there's Prozac, Paxil,
They're SSRIs.
Lexapro,
So the Lexapro,
Cymbalta.
so they're all
A lot of them,
SSRIs.
a lot of the meds that are prescribed in general, they're prescribed for, clinical experience and from the prescriber, and also what has the patient tried before. So what have they tried before? You know what I mean? What has kind of worked for them? What didn't work for them? What side effects did they get from a med that they can't live with? And then you go from there. That's kind of how it is in psych. Like it's more of an art, obviously, art is psych is more of an art than a science. So a lot of the stuff has to do with other, conditions they've had and what they've tried and what we can try now. So yeah. So that's how like that works, like with chosen meds. Yeah. I guess, okay, what else? There is,
And let me pause. So like the SSRIs, right? Those are common for depression, but they also help with anxiety, right? The
yeah,
SSRIs, probably the most common reason those are given out. And it sounds like those, SS, selective serotonin reuptake inhibitors.
yeah.
So they work on your serotonin system, which is associated with feeling good, happy. Like what else is like what is because they each kind of target a different chemical, and they like either try to increase a chemical or decrease it, and then each med maybe increases it in a different way. Like it helps produce more, some blocks the way your brain gets rid of it, so it keeps it and it kind of holds on to more, right? So like an SSRI, what's the significance of serotonin?
So serotonin is actually involved in everything. So there's 12 known serotonin receptors right now. And we don't even know what all of them do. And certain SSRIs interact with certain receptors. And if the receptor is presynaptic, postsynaptic, somatodendritic, then it's going to do different things. And, some serotonin receptors are more densely populated in other parts of your brain versus what I'm saying. So serotonin is literally involved in everything. It's involved in so many things, like guts, like there's serotonin receptors in your periphery, in your central nervous system. Is literally involved in a lot a lot of stuff.
So we have that. We have, then you have kind of the SNRIs, which is serotonin and norepinephrine. We were talking about Effexor and like something like Prestige. And those seem to not, I mean, would you say those aren't always like the first line of defense? Like sometimes, they'll try the SSRI and then kind of go to the SNRIs, which are a little fancier or whatever. Would you say that's usually the case? They'll maybe something like Effexor they'd start, but what is the deal with SNRIs?
Yeah, I would say that's like somewhat how it goes. So, I mean, I guess it's always patient specific. So,
Why would a doctor prescribe an SNRI versus an SSRI?
Maybe they maybe they like them better. Maybe they find that SNRIs are, more effective for whatever they have, like, depression, anxiety. They tend to be better. They're usually better tolerated. They have, a different set of side effects. So like, for example, SNRIs, because they're noradrenergic, they can be kind of activating. Norepinephrine provides some sort of like motivational feelings to get up and go, like dopamine. So yeah. So I guess, yeah.
Cool.
Like, I mean,
I was wondering, like, what is norepinephrine actually? Like, what's the difference between that and, like serotonin? I mean, I don't even know the difference. Like, I know what serotonin does, but norepinephrine, there's a lot of them. There's GABA.
Yeah.
Like a lot of the main, it's like, because I know like from like addiction, like world, like something like cocaine, meth, those really act on your serotonin receptors, right, to get that activating. Then I know, yeah, opiates and your opioid receptors, and alcohol, GABA, cigarettes, nicotine, acetylcholine, right? Kind of all these. That's what like in my addictive world, it's like all these have in common. Are they uh, cause a release of reward chemical because these other effects are rewarding for survival or whatever our body likes the effect, gives
Yeah.
us survival hit, but then we like the after effects of like, ooh, I feel up and this and happy and or this one, it calms me down and relaxes my body, right? So it's like these drugs of abuse work on them, but like meds in a more subtle way will do that, where it's not intoxicating, it's not that's like maybe the difference why they're not addictive. You still get the dependence because you get a slow release of neurochemicals, right? But you're not getting that dopamine. You're not hitting that reward switch where the mouse is going to keep hitting it till it dies instead of eating in a more controlled and safe way. Is that accurate?
Yeah, yeah, that's accurate. Also with that kind of stuff, like if you're talking about like you know, like meth or something, I don't know. We could say what we could say on TikTok, but
Yeah, we can
um
talk about
it also depends on the rate at which a drug or med is absorbed. So, that's what different formulations can help with. Is the slower rate of absorption isn't going to cause that huge like spike of release of whatever like
that.
happy neurotransmitter that you're thinking of. So you're right, like yeah, 100% meds can provide you that slow increase, and it's more controlled versus
Well, yeah, a lot of people are
yeah.
self-medicating. That's why I mean, so many people who use substances have kind of co-occurring mental health, and it's often that they're self-medicating. Like I'm sure I mean, what percentage? You have to say an exact number, but I mean, if I had to guess, probably at least 50% probably of the patients at your hospital on a locked psych unit have some kind of co-occurring disorder, whether it's full-on addiction or substance abuse. Would you say that's roughly accurate? Just
uh 50%.
yeah.
Yeah, probably, yeah.
I mean, I worked more on an adolescent. I mean, I worked in psych. I worked on a locked adolescent unit. That was actually more specialized in dual disorder. So pretty much everyone on my unit did. But then I'd go and I'd work on some of the other units, pick up shifts. And it's like at med time. All the ones that are on like a benzo. It's like they're at the desk at 9 o'clock sharp. Maybe they're maybe it's in their chart they haven't. But it's like it's very common. It's like for someone with schizophrenia, like cannabis is very common and just anything. I mean, it's sometimes rough living with this severe disorder enough
Oh,
that they're winding up at the hospital. They take matters into their own hands.
yeah, yeah, for sure. That's rough. It's rough. And I feel for people
Sure. Do you
that
have a
are
lot of patient interaction? That question came into my mind. Like, how much of it? How often are you working one on one with a patient, or is that not? I mean, I know like Walgreens, like, oh, have a meeting with the pharmacist in this little booth over here. Talk to the pharmacist. But how much of that, like in your role or other pharmacy roles, are you doing direct patient care?
right now when the hospital's extremely busy, it's a little bit less, but usually how it goes is at least at my hospital, like the doctors will beg us almost to come on like rounds with them. Because they feel better, I guess, having like a pharmacist on rounds. So usually, typically, I mean, I guess medium amount, but yeah. But right now, we just don't have the staff. Like we don't have the manpower to be able to go
Yeah.
on, every doctor's rounds or whatever.
Okay, that's super interesting. Do you do you know? Do you have like any just like statistics off the top of your head of like med efficacy of like something like patients who take antidepressants alone for depression tend to have a 25 to 60% improvement of symptoms, or do you have any of those?
Yeah, it's pretty low. With like SSRIs. Yeah,
All right,
the
all right,
efficacy
okay,
rate. Yeah,
fair
the
enough.
efficacy rate is pretty
So why do
low.
we do it? If it's low, I mean, what's the deal with that?
Yeah, this is what we got, like as for meds, like this is kind of what we got right now. Um, but yeah, the SSRIs are like, when you compare them to placebo, they're not that much better. So the
That's
placebo,
disturbing.
yeah,
Like, why do it?
yeah.
I mean, because you have all the downsides, but yeah, maybe we just get a good placebo out of it. But, I mean, we can't really just be giving.
Sometimes, like the placebo effect is very strong. So sometimes when you give a patient a med, they they think like this is going to help, and yeah, the placebo effect is strong, so they feel it. They're like, oh, this is medicine, this is going to help me, and then it helps them. So but yeah, some SSRIs, like, they work better than others, but they're not technically more efficacious than others, but they seem to work better, like an SNRI, because it also works, increases norepinephrine.
Yeah.
Yeah.
So what about something like a Wellbutrin, which you're well known for, the Wellbutrin queen here?
Wellbutrin is probably my favorite, like, antidepressant.
Too.
What? Why did you make that face?
Well, me too. I like it.
Oh, you too?
Yeah,
Uh-uh.
I enjoy it. Yeah, I know. I
You
like.
enjoy. Yeah, I like Wellbutrin for a lot of reasons. So, for example, it works on dopamine. So it's one of the only ones that do that work that have an effect on dopamine. It looks like a stimulant. It's very similar to a stimulant. And usually when you increase dopamine, the side effects from it are a lot better than like from an SSRI. Like, for example, weight gain. So dopamine, I mean, bupropion alone actually helps you lose weight versus, not by much, but it has a weight loss effect, very small, but it's still there, versus SSRIs, which can cause weight gain.
Oh, yeah. Yeah, and I think, for like something like that, sometimes you have these secondary effects. Like some people with, I know it's getting prescribed more often for ADHD as well. People find benefit from Wellbutrin.
Off label. I mean, yeah, it can be used to like off label or augment ADHD, but in my personal opinion, I don't think it would be strong enough for somebody with ADHD. I mean, it might be, everybody's different, but it's not even technically a stimulant, but it's mild. It's a mild stimulant.
Sure. Yeah, I've heard just more commonly off-label or other clients saying that they get some benefit, who are maybe more reluctant to take a stimulant. And oh my God, I mean, everyone's so interested in ADHD nowadays.
Yeah.
You talk about stimulants. Actually, do you know Dr. Kennedy, Patrick Kennedy on TikTok? No,
I'm new here.
you're a new kid on the block. Yeah. I scooped you up
Yeah.
early. I got in at the ground level. I got. But yeah, so I had him on the podcast. We had an awesome episode where, I mean, he's another guy, 500 level class,
Really?
Oh,
And he's on TikTok?
go check him out. And you should check out our podcast that we did. I mean, this guy, he was like top of his class, med school, like brilliant, brilliant dude. And, we just talked about ADHD, and, he is about as big a proponent for stimulants as I ever met. But I mean, we went really deep into the neuroscience and the research on ADHD, and I learned a lot. And, he's helped kind of change my views too, and seeing some stuff on TikTok where I've been more, especially coming from the addiction world, a little more hesitant on, stimulants and, given, you know, it's got the word meth in it, and it's got similar structures to math, but he really kind of dispelled some of those myths, and because you could change a structure just a little bit, he was saying, and has a completely different effect. It could look like meth, but then if you take off like these little horns, or I don't know what the hell you'd call it, then it has like a very different effect, that's very different.
Yeah, for sure. Being an isomer just being like a stereoisomer, like pseudoephedrine and methamphetamine. They are the same structure actually, but they have a different. Well, actually, there's a hydroxyl group on the pseudoephedrine. So, but other than the hydroxyl group, they're the same molecule, except they have a stereo, like an isomer. So, like one bond sticks out and the other one sticks back. Yeah, like that.
Yeah, so
and that makes all the difference.
Yeah, it's a 500 level class. So we got some, I want to do a little Q&A, but I don't want to take up too much of your time. I got to hop off here fairly soon. Someone asked, this is an interesting question. Maybe you would know this. Let's see. Someone asked, where did it go? They said a certain drug not prescribed in the U.S. Why won't they prescribe modafinil in the U.S.?
It is prescribed in the U.S.
All right, there you have it. On record, it's prescribed in the U.S. Any advice to aspiring pharmacists?
Good luck. No, just kidding. Yeah, you got this. If you like meds, that I think you got this. If you're willing to suffer in school, you got this. Yeah. Advice for like a kid in like pre-pharmacy school or something.
Someone
like
just said advice for a professional. I mean, there were some other pharmacists on here. There was someone on here who was a pharmacist in training, and who knows who's going to listen to this. So,
yeah. Always, I guess, I don't know. I don't know. I don't want to be cheesy, but always just think about like the patient.
Always think about the patient. Yeah.
For example, if you're too scared to bother a doctor for some reason, do it. Like if your spidey senses are tingling, do it. It's for a patient. So always do it. Like, don't even if you're worried about like bothering anybody, do it. Just do it.
Yeah. Well, sometimes it's intimidating, right? Especially if you're like newer, younger, whatever, and you got, you're working with doctors, it could be intimidating, and they're fancy doctorness, and and you don't want to question them. It's kind of that like, I call it like groupthink or peer pressure, social pressure. It's like, so it's like if I say, all right, what's 3 + 3? Someone goes 6, and then I go, no, it's not. And you're like, wait, what are you talking about? And I'm like confident enough, right? So, like, you start to question it. You're like, wait a minute. It's like, I'll bet you $1,000 it's not. Then you're like, then you start questioning, even though it's like so obvious, right? There's this like psychological, and I think you see that sometimes, right? Like, an authority figure, doctor. It sounds like it's important to ask questions and know your competence, and don't be
the confidence thing is
because doctors make a lot of mistakes. They do.
Everybody does. Everybody makes mistakes.
Exactly. Even doctors, who knowing everything.
Yeah, and confidence comes with time.
Absolutely. So where can people, well, first of all, what any resources you recommend for mental health, folks interested in mental health, folks struggling with mental health, want to learn more about any resources that you recommend to folks?
Well, I guess to like a layman, so I read a lot of literature, which is not easy to read. So yeah, that's how I mostly do it. So okay. I guess the best thing to do if you want to learn about your med really fast, like say you want a new med, just type in on Google the med's name and then write mechanism of action and look in the images. So then you can kind of see what's going on. Yeah. So look at the images, because the images might be a little nicer to look at than like whatever the first text comes up. Text might be, too full of big words, but then an image, So look at the image. I always look at the structure,
Yeah, that's really good advice. Yeah, it's sometimes easier when you see it.
And you might remember the picture, better too.
So, where can people find you? Where do you want people to go for everything, Haley?
Well, I'm only on TikTok, and
What's your handle on Insta?
My handle on Instagram is Your Keto Pharmacist. It's keto because that's what I started off as.
Okay, yeah, you said earlier. Remember I told you one time about my experience with keto, where my
Yeah,
cholesterol went to like 190. But
that'll happen. I don't know if you want to talk
well,
about.
you eat pork rinds and like cheese and bacon
Yeah.
for breakfast. But that's a topic for another day. What? Okay, so I ask everyone, what is your end game as far as making content? Like, what do you hope to accomplish? Are you trying to grow this? Like, where do you see this going, or what would you ideally like? What are some of your goals?
No idea. No idea. Yeah, I guess I just start posting a video. Yeah, why? What do other people say? They have like a plan? Do people have a plan? And I don't have a plan.
I don't know. I don't
Should I
know.
have a plan?
No, I think just keep posting good content. And I think opportunities present themselves. And I don't know. You're again. I wanted you on here for a reason. I think what you're doing is extremely unique. There's plenty of therapists out there. I think I have a little niche that I found, but I think for someone is knowledgeable about meds that's not necessarily a doctor. There's not a, I don't know, there's probably a pharmacist talk. There's a TikTok for everything. But I've never seen a pharmacist who specializes in mental health meds who um, is able to educate and convey the content like you do. And
Wow, thanks.
I'm serious.
That's really nice.
Yeah, I'm not just trying to blow smoke here. I think you know you you there's a lot of potential. There's a lot of good in what you do. And you're only 28 years old. You're clearly sharp. I think expound this last year of whatever you've done and gain. I don't know, you have 20,000, 30,000 followers, something. And um, imagine where you'll be in a couple of years. So I think just keep making, I guess my unsolicited advice, just keep making good content and see what opportunities open up. I could see a book in your future. Um,
Everybody says that. I know you have a book. I know you have a
working
book,
on it.
right?
I'm working on it, and I do give
How
out.
much work is it? It's a lot of work, right? I can't
It is a
imagine.
lot, but yeah, it's a ton of work, but you just do it slowly. You do a little bit every day, and then all of a sudden you have a book. And whatever the book is you do, I'm sure it'll be a lot more, complex and in depth. I like to, hit the surface and in the content I do try to make it like as palatable as possible and, educate in a fun way, to take maybe concepts that are more complicated and make them simple, fun, easy. And I know that, you like to dig deep, but I could see, I could see people.
Yeah, I just don't like some people appreciate it. Some people they appreciate that my content's a little higher level because they feel like I'm not treating them like they're dumb because they're not. And yeah, so I don't like to over I know you're not oversimplifying it, but I would rather keep my content at this level than making it too simple. You know what I mean? Because it doesn't really when you go too simple, it doesn't really explain it. It doesn't really answer the question.
It's true. And I think a lot of us, like therapists, whatever, it's like it engages people in therapy. But, it's a lot of like, I want to see you write it, symptoms of depression. Da, da, da. They're like pointing, the little bubble comes up and it's like, touch your therapist, heal your trauma. It's like, that's great. And I do some of that, in jokes and comedies, like half of what I do. But then, sometimes I do like, all right, let's break this down. And, people really appreciate that when I do the more, maybe I don't get as many views. Some of them do, but like really breaking down depression. Here's what the DSM, here's how we here's as therapists, here's how we diagnose this, here's some of the science, and people do appreciate that. So, but yeah, no, I think, what you're doing is really unique, and I
You
want to,
too, Evan.
I'm a fan, as a fan, I want more Haley, I want more Haley content because I learn a lot from you. And
Wow. Thank you, Evan. You too. I learned a lot from your videos too and your lives. And I love it. Yeah. I
I
mean,
love having you in the lives. You're a fun participant.
you, I love hearing your perspective too. So you're like, I love it because, obviously like patients talk more to you, about how they're feeling and about how their meds are making them feel. And I don't always get that, and it's really cool. It's really cool.
Oh, thanks.
Yeah, it's very valuable.
Mutual respect and admiration. I love it. Well, I'm really excited to, keep on this journey, our TikTok paths. And yeah, I really appreciate you being on. We'll stop the recording here, but thank you so much. I really appreciate you being on and pushing your comfort zone. That'll be my therapist. And I know you're a little anxious, but you push your comfort zone and you did awesome. I love it.
For sure, for sure. It was nice being a guest on your podcast slash YouTube slash TikTok live.
Never for sure. All right. Well, Haley, we'll talk to you soon.
All right, have a good one.
See ya.
Bye.